Welcome to the deep dive. Today we're getting into computed tomography, CT. It's really changed the game for finding and treating blood vessel problems.
Absolutely. That old way, conventional arteriography is just not the go-to standard
I
anymore.
really know.
And we're drawing heavily from Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition. It's packed with info.
Right. So our mission today is to kind of unpack the basics of CT. How it works, how it got here, and crucially, how it's used now in vascular surgery.
Exactly. We want to get to the core principles.
Okay, so why should you, listening in, care about the guts of a CT scanner? Well, look, whether you're in the medical field or just, curious about tech and health,
Mm-hmm.
understanding CT gives you a real insight into some amazing medical progress.
Mm-hmm.
And honestly, it makes you way more informed if you're ever part of conversations about treatments or reading health stuff.
Yeah, it helps connect the dots.
We'll try to make the techie bits pretty straightforward. So let's start way back. What was the original problem CT was trying to fix?
Well, the big issue with standard x-rays, the basic ones, is that everything inside you gets superimposed, all stacked up on one flat image.
Right, like trying to see individual instruments in an orchestra pit from the balcony, like a big jumble.
That's a good way to put it. Yeah, you lose all the depth, all the separation.
So what was the first crack at solving that before CT?
There was this earlier technique, planigraphy or just tomography. It was actually pretty clever for its time.
Yeah.
They physically linked the x-ray tube and the film you see on opposite sides of the patient. And then they'd move them in opposite directions, pivoting around a specific point inside the patient.
So like a seesaw motion.
Sort of, yeah. And the effect was that structures right at that pivot point stayed sharp, stayed in focus,
Okay,
while everything above and below that plane got blurred out.
gotcha. Like using shallow depth of field in photography, blurring the background to focus on the subject.
Exactly like that. It was a big improvement, used for years. But the real revolution came in the 70s.
Right, that's when computers started getting powerful enough.
Precisely. That, combined with the idea of transverse axial scanning, basically scanning across the body slice by slice, and then using computation to reconstruct the image, that's where computerized axial tomography, or CT scan, came from.
Which we mostly just call CT now.
Yep, just CT.
And wasn't it developed kind of simultaneously by two different people, working totally separately?
It was quite remarkable, really. Sir Godfrey Hounsfield over in the UK, working for EMI.
The music company. Seriously.
The very same. And Alan Cormack, a physicist at Tufts University here in the States, completely independent work.
Wow.
They both figured out the complex math and the hardware needed to make it work, but building the scanner, figure out the reconstruction algorithms. It was a huge undertaking.
And the first machines, where did they land?
Hounsfield's first EMI scanner went into Atkinson Morley's Hospital in Wimbledon, UK, back in '71, and the first US one was at the Mayo Clinic.
And the speeds. I read they were incredibly slow.
Oh, painfully slow by today's standards. We're talking 4 minutes just to acquire the data for 2 brain slices.
2 slices.
And then another 7 minutes for the computer, which was massive back then, to actually process that data and create the images.
It's, yeah, hard to imagine now.
But it was revolutionary, totally changed diagnostics. So much so that Hounsfield and Cormack shared the Nobel Prize in 1980.
Deservedly so.
Yep.
And those fundamental ideas, they still underpin modern CT, right?
Absolutely. The core physics and the basic concept of reconstruction haven't changed, even if the machines are vastly faster and more sophisticated.
Okay, let's get into those basics. How does a CT scanner actually sees inside us? What's the core mechanism?
At its heart, it's pretty simple. You've got an emitter shooting out a very thin focused beam of X-rays.
Okay.
And directly opposite, a detector that measures how much of that X-ray beam gets through.
So it measures how much the beam is weakened.
Exactly. That weakening is called attenuation.
Yeah.
Different tissues, bone, muscle, fat, air, they all attenuate or block the X-ray beam to different degrees.
Makes sense. Bone blocks more than air.
Right. But the key is, it doesn't just send one beam, it sends many beams from lots of different angles, all slicing through the same cross-section of the body.
Okay, so it's gathering data from all around.
Precisely. It rotates around you, taking hundreds or even thousands of these attenuation measurements from every angle.
And then the computer steps in.
Yep. All that raw data gets fed into the computer, which uses complex algorithms building on the work of Cormack and Hounsfield to calculate the density of the tissue at every single point within that cross-sectional slice.
On the density value, that's the Hounsfield unit.
That's it. The CT number, measured in Hounsfield units, or HU, named after Sir Godfrey, of course.
Cool. What's the scale like? What are the numbers?
It's a standardized scale. Air is defined as having a very low density, so it's way down at -1,000 HU.
Okay.
Water is the reference point, set at 0 HU.
0 for water. Got it.
Fat is less dense than water, so it's in the negative range, maybe -20 to -100 HU, roughly. Soft tissues, like muscle and blood too, are a bit denser than water, usually around +40 to +60 HU.
Hmm.
And then really dense stuff like cortical bone is way up at the top end, could be +1,000 HU or even higher.
So quite a wide range. Are those numbers exact?
They're pretty consistent, but, there can be slight variations between different scanners or specific settings, but those general ranges hold true.
Okay, so the computer calculates an HU value for every little spot in the slice. How does that become the black and white image we see?
The computer essentially creates a grid, a matrix representing that slice. Each tiny square in the grid is a pixel, a picture element.
Right.
And the computer assigns a shade of gray to each pixel based on its calculated HU value. High HU values, like bone, get mapped to white or very light gray. Low HU values, like air, get mapped to black. And everything in between gets shades of gray.
So it's basically a density map translated into a visual image.
That's a perfect way to summarize it.
Okay, fundamentals down. Now, obviously, scanners have evolved massively since the 70s. Take us through that evolution.
Right, those first-gen scanners, the single-slice sequential ones, they could only scan one slice at a time. You'd stand, the table would move a bit, you'd scan again.
Slow going?
Very. And with that initial 160 by 160 matrix resolution, they were really only practical for things that didn't move much, like the head. Trying to scan the chest or abdomen. Forget it. Breathing, heartbeat, too much motion blur.
Yeah, that makes sense. So what was the big leap that changed that?
That was spiral or helical CT. This was a major breakthrough.
How did it work?
They introduced something called a slip ring gantry. This let the X-ray tube and the detector spin continuously in the same direction around the patient.
No stopping and starting.
Exactly. And crucially, while the tube was spinning, the patient table moved smoothly through the gantry.
Okay, I can picture that.
Yeah.
Like the X-ray beam tracing a spiral path.
Precisely. Like the stripes on a barber pole wrapping around the patient. And this meant they could acquire data not just slice by slice, but over an entire volume of the body in one continuous go.
Wow, that must have been way faster.
Much faster. And it had other huge advantages. Because you have this continuous volume of data, you can retrospectively reconstruct images or slices at any level within that scanned volume.
You could make really thin slices afterwards.
Yep, very thin slices. And you could even make the slices overlap without giving the patient any extra radiation dose.
That seems important. Why would you want overlapping slices?
It helps create smoother, better quality 3D reconstructions later on. Now, sequential CT could do overlapping slices, but you had to physically scan each one, increasing the stand time and the radiation dose.
Got it. So spiral was faster, more flexible, less dose for overlap. Any downsides?
Well, the reconstruction process for spiral data was a bit more complex, and sometimes could introduce subtle artifacts compared to the cleaner slice-by-slice acquisition of sequential CT, which is actually why sequential scanning is still sometimes preferred for specific brain imaging, where those tiny artifacts might matter more.
Interesting trade-off. Okay, so spiral helical was a big step. What came next?
The next massive leap was multi-slice CT, or multi-detector CT, MDCT.
Or detectors.
Exactly. Instead of just a single row of detectors opposite the X-ray tube, these scanners have multiple parallel rows of detectors lined up along the length of the patient, the Z-axis.
So they can capture more data with each rotation.
A lot more data. In a single rotation, which now happens incredibly fast, like 0.2 or 0.3 seconds.
That fast?
Oh, yeah. In that fraction of a second, they can acquire data from multiple thin slices simultaneously or cover one large volume very quickly. It drastically reduced scan times again and allowed for imaging of much larger areas of the body in a single breath hold.
Which must have basically killed off motion artifacts for most things.
Pretty much, yeah. It dramatically reduced artifacts and just improved image quality overall. That's why multi-detector scanners have almost completely replaced the older single-row spiral systems.
And the image detail improved too.
Definitely. Along with the faster scanning, computer power kept increasing, allowing for bigger matrices. We went from that early 160 by 160 to the standard 512 by 512 matrix you see today. Much finer detail.
And you mentioned pixels before, but the volume scanning, it's really voxels, right?
That's the technically correct term, yes. Since we're acquiring data in 3 dimensions, each point in the dataset represents a tiny cube of tissue, a volume element, or voxel. The 2D images we look at are just representations of that 3D data.
Wait, so we've got these incredibly detailed 3D data sets.
Hmm.
But how do we actually see the blood vessels specifically? They're just soft tissue, density-wise. That's where CTA comes in, computed tomography and
You
geography.
get it. On a non-contrast CT, blood vessels look pretty much the same density as the surrounding muscles and organs. Hard to pick them out.
Right.
The key is injecting an intravenous contrast agent, usually containing iodine. Iodine is very dense to X-rays.
So it makes the blood much brighter on the scan.
Exactly. It significantly increases the attenuation, the HU value of the blood flowing through the vessels, making them stand out brightly against the background tissues.
And this became practical with the fast scanners.
Absolutely. Fast spiral and multi-detector CT was the enabler for CTA. You need to scan a whole region, like the chest or abdomen, while that temporary bolus of contrast is passing through the arteries or veins you want to see.
So the timing has to be perfect.
Spot on. Scan too early, the contrast isn't there yet. Scan too late, it's already washed out.
How do they nail the timing?
Modern scanners use clever software, often called bolus tracking or automated triggering.
Okay.
They take quick, low-dose monitor scans at one specific level, say the aorta. The software watches the HU value in that vessel. When it jumps up to a preset threshold, meaning the main bolus of contrast has arrived.
Bang, the main scan starts automatically.
Exactly. It triggers the full diagnostic spiral scan at just the right moment.
That's pretty smart. What about the contrast itself? What do they need to think about?
Several things. The concentration of iodine in the contrast agent matters, how fast you inject the injection rate, and the total volume you give the patient.
Are they using less contrast now than they used to?
Generally, yes. Faster scanners mean shorter scan time, so you don't need the contrast to hang around as long. Techniques have improved. We've gone from maybe 120, even 180 milliliters historically down to often less than 100 milliliter now for many studies.
That's good. Less load on the kiddies.
Definitely. There are also techniques like split bolus injections.
Super bolus.
Yeah, where you give parts of the contrast dose at different times. This allows you to potentially capture both the arterial phase when arteries are brightest and the venous phase when veins are bright, all within a single scan acquisition. Saves the patient an extra scan and extra radiation dose.
Neat trick. Any other contrast factors?
One interesting thing is that if you lower the energy of the X-ray beam, the KVP setting we talked about, it can actually make the iodine appear even denser, enhance its visibility without changing the actual amount injected. So that's another parameter they can tweak.
Okay, let's shift gears slightly. Before the scan even starts, there's a whole bunch of settings that need to be programmed in, right? The acquisition parameters.
Absolutely. Every CT scan follows a specific protocol, which is basically a recipe optimized for the body part being scanned and the clinical question being asked. It dictates all the pre-scan settings.
Like what?
Things like the X-ray tube settings, KVP and MAs, the gantry rotation speed, how long the spiral scan needs to be, the pitch, the collimation or beam thickness, plus patient instructions like breath holding, and of course, the detailed plan for the contrast injection if it's a CTA.
And these are fixed once the scan starts. You can't change them later.
That's right. These are acquisition parameters. Once the raw data is acquired, it's acquired. You can process it differently afterward, but you can't change how it was originally captured. That's why getting the protocol right beforehand is crucial.
Okay, let's break down a couple of those. KVP and MAs again. Remind us.
Sure. KVP, kilovolts peak, sets the energy or penetrating power of the X-ray beam. Higher KVP penetrates better, which you need for larger patients, but it can slightly reduce the contrast between different soft tissues.
Okay.
Lower KVP doesn't penetrate as well, but it actually increases tissue contrast and, as we said, makes iodine pop more. So you might use lower KVP for smaller patients or specific CTA applications.
And MAs.
MAs, milliampere seconds, is about the quantity of X-rays. More X-rays, meaning higher MAs, reduces image noise or graininess, giving you a smoother picture. But
more radiation dose.
exactly. It's a direct trade-off. So you want the MAs high enough for a good quality image, but as low as reasonably achievable the LR array principle to minimize dose. KVP and MAs are linked. Changing one often means you adjust the other.
Got it. What about collimation?
Collimation is about shaping the X-ray beam, specifically its thickness as it comes out of the tube. This fundamentally determines the thinnest possible slice you can reconstruct later on and impacts the resolution along the length of the patient, the Z-axis resolution.
Okay. And pitch. You mentioned that. Sounds technical.
It's basically a ratio.
Yeah.
It compares how far the patient table moves in one full 360-degree rotation of the gantry
Uh-huh.
to the total width of the X-ray beam hitting the detectors, which is set by the collimation.
What does that ratio tell you?
It tells you how much overlap or gap there is between successive spirals of data acquisition. A pitch greater than 1, maybe up to 2, means the table moves faster, covering ground quickly with some gaps between the spirals. Good for speed, lower dose, but risks missing tiny details or causing artifacts if it's too high.
And less than 1.
Pitch less than 1 means the spirals overlap significantly. The table moves slower. This gives you really good data for high-quality 3D reconstructions, but increases the scan time and the radiation dose because you're scanning the same tissue multiple times.
So it's another balancing act.
Always. Finding the sweet spot for pitch depends on the clinical need speed versus detail versus dose. The calculation is a bit different for multi-slice scanners, sometimes called P, but the principle's the same.
What about scanning time limits and patient positioning?
Older scanners used to have limits on how long the tube could run continuously before overheating, maybe 20 seconds or so. Modern scanners can typically go much longer, maybe 100 seconds or more if needed. Positioning is key, too. Getting the patient centered in the gantry is important for image quality.
And the arms up thing.
Yeah, for chest and sometimes abdomen scans, having the patient raise their arms above their head gets them out of the way, preventing artifacts called beam hardening that can streak across the image.
Right. And contrast protocols, we covered that timing, volume, rate, all tailored.
Yep, critical pre-scan planning.
You also briefly mentioned dual energy or dual source CT. Why isn't that standard for vascular yet?
It's a really interesting technology. Uses 2 separate X-ray tubes, or one tube rapidly switching energies. It can give you more information about tissue composition, like differentiating iodine from calcium sometimes.
Sounds useful.
It can be, but it's also more complex hardware, more complex reconstruction, and often sophisticated software on modern single-source scanners can achieve similar diagnostic results for many routine vascular questions without that added complexity. It's finding its niches, but not quite mainstream for all vascular work yet.
Okay, that covers the before the scan setup. Now, after the raw data is acquired, what adjustments can be made? The post-scan parameters.
Right, now we're talking about how you reconstruct and display the images from that raw data volume. One key thing is the increment, or reconstruction index.
Increment.
This is the spacing between the centers of the reconstructed slices. Say you acquired the data with the potential for 1 millimeter thick slices. You could choose to initially reconstruct images every 3 millimeter.
Why do that? Fewer images to look at.
Exactly. It reduces the initial image count, making review faster. But because you still have the raw data, if you see something interesting or need more detail in a certain area, you can always go back and reconstruct images closer together, say every 1 millimeter, or even overlapping at 0.5 millimeter increments just for that region.
Flexible. What about the slice width or thickness itself?
You can also choose the thickness of the reconstructed slices. Again, using that raw data, you could reconstruct 1 millimeter thick slices for fine detail, or maybe thicker 5 millimeter slices.
Why thicker?
Thicker slices average more data, which reduces image noise, making them look smoother. And again, fewer images, less data to store and manage. The thinnest possible slice is always limited by the original beam collimation used during acquisition, though.
Gotcha. And field of view, FOV, we touched on that for resolution. Can you adjust it after?
Yes, you can apply a reconstruction FOV that's smaller than the original scanned FOV. If you're focused on a small structure, using a smaller FOV for reconstruction effectively zooms in, making the pixels smaller relative to the anatomy, which increases spatial resolution for measurements.
But you mentioned a trade-off.
Yeah, sometimes zooming in like that can make image noise more apparent. It doesn't change the noise that was acquired, but it can make it look more prominent relative to the smaller structures.
Okay. Then there's windowing. Window width, window level. Sounds like photo editing.
It's very similar. It's how you control the brightness and contrast of the image displayed on the monitor. It doesn't change the underlying HU data, just how it's shown.
How does it work?
The window level, WL, sets the center HU value that will be displayed as mid-gray. The window width, WW, sets the total range of HU values around that center that will be spread across the entire grayscale spectrum, from black to white.
So a narrow window.
A narrow WW, say 400 HU, is good for looking at soft tissues where the densities are all quite similar. It exaggerates small differences in HU values, enhancing contrast between, say, muscle and fat.
And a wide window.
A wide WW, maybe 1500 HU or more, is used when you need to see structures with very different densities simultaneously, like the lungs, mostly air, low AQ, and the ribs, bone, high HU. It compresses the grayscale, so you lose subtle soft tissue contrast, but you can see the extremes without anything being pure white or pure black.
Makes sense. You adjust the window to see what you need to see. Finally, the reconstruction algorithms. Filtered back projection versus iterative reconstruction. Big difference.
Huge difference, yeah. Filtered back projection, FBP, was the original workhorse. It's a direct mathematical method to create the image from the projection data.
But it needed filtering.
Right. The raw reconstruction is often a bit blurry, so they apply filters or kernels to sharpen it, but there's a trade-off. Kernels that sharpen the image a lot, high spatial resolution, also tend to amplify noise. Kernels that smooth out noise also blur fine details. You had to pick the best compromise kernel for the task, like a sharp bone kernel or a smoother soft tissue kernel.
Yeah, okay, necessary compromise back then.
Uh.
How did iterative reconstruction IR change things?
IR became feasible as computers got much, much faster. It's a totally different approach. Instead of a direct calculation, it starts with an initial guess of the image, and then it simulates the scanning process, compares the simulated data to the actual raw data that was measured, figures out the difference, the error, and then adjusts the image guess to reduce that error.
And it does this over and over.
Exactly. It iterates, refining the image step by step. Crucially, it can incorporate sophisticated models of the scanner physics, the X-ray beam characteristics, and even the statistical nature of noise itself.
What's the benefit?
The massive benefit is noise reduction. IR algorithms can reduce image noise by 70, 80, even 90% compared to FBP without sacrificing spatial resolution.
Wow. So you can get sharp images and low noise.
Pretty much. Or, the really exciting part, you can deliberately acquire the initial data with a lower radiation dose, which would normally be too noisy with FBP, and then use IR to clean up that noise, effectively achieving a diagnostically good image at a significantly lower dose to the patient. That's been a major driver for adopting IR.
That's a huge win for patient safety. Any downsides to IR?
The main historical downside was computational time. It just took a lot longer to reconstruct images. But with modern computing power, that's much less of an issue. The images can also sometimes look a little different, maybe slightly blotchy or waxy compared to FBP, which radiologists had to get used to. The newest algorithms are even fully model-based, getting even better results.
Amazing progress.
Yeah.
Okay, what about dynamic and gated scanning? When do those come into play?
Dynamic CT is about looking at function over time, specifically tissue perfusion, how blood is flowing through the tissue.
How's that done?
You basically park the scanner over one location, inject contrast, and then take rapid sequential scans at that same spot over maybe 30, 60 seconds.
Ah, so you see the contrast arrive in the arteries, then soak into the tissue capillaries, then wash out through the veins.
Exactly. You can generate time density curves to quantify perfusion. It needs scanners that can cover a decent area quickly, so high slice count scanners, like 256 slice or more, are ideal. It's mainly used for brain perfusion, like in stroke, and cardiac perfusion.
Got it. And ECG-gated or triggered scanning. Sounds like it's for the heart.
Precisely. The heart is always beating, obviously, which causes major motion artifacts if you're trying to image it, or the vessels right next to it, like the coronary arteries or the ascending aorta.
So you link the scan to the heartbeat.
Yep. You connect ECG leads to the patient, and the scanner uses the electrical signal from the heart to time the X-ray exposures.
Are there different ways to do it?
Two main ways. Retrospective gating means you scan continuously throughout the heart cycle while recording the ECG. Then, afterwards, the computer sorts the data and reconstructs images only from specific phases of the cycle, usually diastole, when the heart is most still.
Advantage. Disadvantage.
Advantage is you have data from the whole cycle, if needed, good for looking at heart function. Disadvantage is you scan the whole time, so the radiation dose is higher, and since you're only using parts of the data for each phase, the images can be a bit noisier. It's often used for coronary artery imaging.
Okay. And the other way?
Perspective gating, or triggering. Here, the scanner uses the ECG signal to predict when the quiet phase is coming, and it only turns the X-ray beam on during that pre-selected window.
So less radiation.
Significantly less radiation, which is a big plus. The downside is you only get images from that specific phase you chose beforehand. If there is an unexpected finding best seen in another phase, you don't have that data.
Trade-offs again. Okay, we have the data, maybe reconstructed it cleverly.
Yeah.
What other post-processing can make these images even more useful?
One of the most powerful and routine things is multiplanar reformatting, or MPR.
Reformatting.
Yeah, remember, we acquired a 3D volume of data. MPR lets us slice through that volume in any direction we want, not just the original axial cross-section view.
It's like front to back, side to side.
Exactly. Coronal views, front to back, and sagittal views, side to side, are standard. But you can also create oblique planes angled any way you need to follow the path of a specific blood vessel, for example. Really helps understand the 3D anatomy.
Must be crucial for planning surgery. What about measurements? Are they straightforward?
Well, they're better than they used to be, but still need care. On simple axial slices, if a vessel isn't perfectly perpendicular to the slice, you get an oval cross-section, not a circle. Measuring the diameter accurately on an oval is tricky.
Right. Which diameter do you pick?
Exactly. Spiral CT with MPR helps hugely because you can reformat the image so it is perpendicular to the vessel at the point you want to measure. That gives you a true circular or near circular cross-section for a much more accurate diameter.
Okay, perpendicular views are key. What about length?
Length is harder, especially in curvy vessels. You can try drawing a line along the vessel on MPRs, but it's not always precise. There's also curvilinear reformatting, which tries to straighten out the vessel electronically.
Does that work well?
It helps visualize the whole length, but it can distort angles and isn't always perfect for precise length measurement, especially for things like planning stent graft lengths.
So what's the best way for measurements, especially for complex stuff like aneurysm repair?
That's where 3D reconstruction really shines, combined with those perpendicular reformats for diameter. Specialized software, often used for endovascular planning, can automatically detect the center line of flow within a vessel, even a really tortuous one.
Centerline.
Yeah, it tracks the middle of the blood flow path. Then it can calculate the precise length along that center line, which is exactly what surgeons need for sizing grafts. It's incredibly valuable.
Speeds things up too, I bet.
Massively. Quickly understanding the aneurysm's shape, where it starts and ends, finding suitable neck lengths for sealing the graft. It's all much clearer with good 3D CTA.
You also mentioned volume measurements earlier. How do those fit in?
That's another powerful application of 3D models.
Yeah.
Instead of just measuring diameter, you can calculate the total volume of an aneurysm sac, for instance.
Why is that better?
Studies suggest volume changes can be detected earlier and more reliably than diameter changes, especially after endovascular aneurysm repair, EVAR. An aneurysm might not get wider, but if its volume starts increasing, it could signal a leak, an endoleak that needs attention.
So volume could be a better marker for follow-up.
Potentially, yes. Some think it might become the gold standard for monitoring EVR patients, triggering follow-up or reintervention based on volume changes rather than just diameter.
Fascinating. Okay, let's dig into these 3D reconstructions more. How are they made?
It leverages the speed of modern scanners, powerful computers, and clever software. The software essentially goes through the 3D voxel dataset and selects voxels based on their HU values.
So, like, show me all the voxels with bone density.
Exactly. Or, for CTA, show me all the voxels with the high density of contrast-filled blood.
But what about calcium in the vessel walls? That's dense too. Does it get included?
Good point. Yes, dense calcium often falls into the same HU range as contrast, so visualizing just the vessel lumen can be tricky if there's a lot of calcification. Sometimes software tries to electronically remove overlying bone.
Like skull around brain arteries.
Right. That can be done semi-automatically or manually, but removing calcium within the vessel wall itself without removing the contrast is much harder. Usually the calcium is included in the 3D view of the vessel.
Okay. How are these 3D views typically displayed? You mentioned SSD.
Shaded surface display, SSD, is very common. It creates what looks like a solid, opaque surface of the structure. The software adds shading based on virtual lighting to give it a sense of depth and shape.
Good for overall anatomy.
Yeah, great for getting a quick grasp of complex spatial relationships, like how vessels branch, but because it's just the surface, you don't see inside the vessel or get fine detail.
What about MIP? Maximum intensity projection.
MIP is different. It's usually displayed as a 2D image, but it's created by casting rays through the 3D volume and displaying only the brightest voxel encountered along each ray.
So it highlights the contrast.
Exactly. It's excellent for showing contrast-filled vessels, often giving a good overview, maybe in a coronal projection. It also makes calcifications very obvious because they're also high density.
Downside.
In heavily calcified vessels, the bright calcium can sometimes overwhelm the image and actually obscure the view of the contrast-filled lumen inside. You might not be able to see if there's a stenosis behind the plaque.
So SSD shows the surface, MIP shows the brightest stuff. Anything else?
There are more advanced techniques like multiple object SSD or volume rendering, VR. VR is more sophisticated than SSD. It tries to show depth and transparency. Multiple object displays can assign different colors or transparencies based on density.
Like showing bone, contrast, and maybe soft plaque differently?
Potentially, yes. You could show the bright contrast lumen, the even brighter calcified plaque, and maybe try to depict the lower density non-calcified plaque or thrombus, though CT alone isn't great at telling those two apart based purely on density. Gives a more complete picture than just seeing the contrast.
But still, these are 3D models on a flat 2D screen, right?
That's the inherent limitation. True depth perception is tricky. There's specialized viewing software, even some experiments with actual 3D monitors trying to overcome that, but standard viewing is still 2D projection of 3D data.
Okay, this is incredibly powerful tech. Let's pivot to clinical applications.
hmm
Outside the heart and brain, where is CT really indispensable in vascular disease?
Aortic disease is a huge one. Aneurysms, dissections, traumatic injuries. CTA is pretty much the #1 tool.
Why so dominant?
Fantastic spatial resolution. The ability to do those 3D reconstructions for accurate measurements, absolutely critical for planning repairs, especially endovascular ones, EVAR-DEVAR. You can see tiny details like small branch arteries or subtle signs of endoleak after repair.
And it's fast for emergencies.
Crucial. In an acute aortic dissection or rupture, speed is vital. Modern CT delivers that. For the ascending aorta, near the heart, using ECG gating helps freeze the motion for clearer images.
Any advantages over MRI for the aorta?
Big ones are imaging calcium essential for planning stent graft landing zones and dealing with existing metallic stents or grafts. CT has far fewer artifacts from metal than MRI does.
Okay, aorta covered. What about blockages lower down? Peripheral arterial occlusive disease, PAOD, in the legs.
Here, both CTA and MRA, magnetic resonance angiography, are generally considered excellent. CTA's strengths are speed and reproducibility. You can often scan from the aorta all the way down to the feet in one go.
Needs good contrast timing though, right?
Absolutely critical to catch the contrast wave as it moves down the legs. But the high resolution is great for defining exactly where narrowing stenosis are, how severe they are, and planning interventions. It's also proven very accurate for assessing the small runoff vessels below the knee.
Any challenges with PAOD?
The main one, especially in smaller vessels, is differentiating dense calcium in the vessel wall from the bright contrast inside the lumen. Sometimes it can make a stenosis look worse than it is. Interpretation needs care.
What about arteries in the neck? Carotid stenosis.
CTA is very accurate there too. It's often less bothered by heavy calcification than ultrasound might be. It gives great anatomical detail and can usually distinguish a complete blockage, occlusion, from a very tight stenosis better than ultrasound. Plus, you can often extend the scan to include the aortic arch where the carotids originate, and even look at the arteries inside the head if needed.
Okay. How about arteries to the kidneys or intestines? Renal and splanchnic arteries.
Again, CTA and MRA are both pretty good, especially for detecting problems in the main proximal parts of those arteries. MRA can sometimes struggle a bit more with motion artifacts in the smaller, more peripheral branches because breathing affects the abdomen.
Main advantage of MRA there.
Avoiding iodine contrast. If a patient has significant kidney problems, MRA avoids the risk of contrast-induced nephropathy, CIN. Although the gadolinium contrast used in MRA has its own, albeit rare, risks in severe renal failure, NSF. There are non-contrast MR techniques too, but they might not show the vessel wall detail as well.
We focused on arteries. Does CT play a role in vein problems?
It can, yes. With the right timing for the contrast, a venous phase protocol, CT can diagnose things like blood clots in the abdominal veins, like mesenteric vein thrombosis. And CT pulmonary angiography, CTPA, has basically replaced older methods for diagnosing pulmonary emboli, clots in the lungs.
But for leg veins, like DVT,
For peripheral veins, duplex ultrasound is usually the first choice. It's non-invasive and gives flow information. If cross-sectional imaging is needed for veins, MR venography, MRV, is often preferred over CT.
lastly, what about vascular malformations? Those complex tangles of vessels.
CT's role there is pretty limited. It might help characterize high-flow lesions like AVMs, arteriovenous malformations, or AVFs, arteriovenous fistulas, but it's not great for seeing the really fine details of the nidus, the core tangle of vessels, and it's not very helpful for low-flow malformations because CT doesn't show soft tissue differences as well as MRI.
So ultrasound and MRI are better for malformations.
Generally, yes. They're the go-to modalities for most vascular malformations.
Okay, so CT is amazing, but not perfect. We touched on contrast risks. What about the radiation? That seems to be a growing concern.
It absolutely is. Public and medical awareness of radiation dose from CT has increased significantly, especially as CT use has just exploded over the last couple of decades.
Is the risk significant?
It's complex. Each individual scan carries a very small risk, but the cumulative effect of multiple scans over a lifetime and the sheer number of scans being done across the population does raise concerns about a potential small increase in lifetime cancer risk.
Didn't newer technology promise lower doses?
It did, and in many ways, it delivered iterative reconstruction, for example. But paradoxically, the demand for ever higher image quality, thinner slices, and advanced post-processing often pushed clinicians to use techniques that inherently required more radiation initially, relying on the tech to make up for it. Plus, CT is now used for screening colon cancer, lung cancer, coronary calcium.
Right, more scans being done on healthy people.
Exactly. So while the risk from any one scan is low, the population burden is something we have to be mindful of. Some estimates suggest a small percentage of future cancers might be attributable to medical radiation, mostly CT. It really emphasizes the need for justification-only scan when necessary, and optimization use the lowest dose possible, LARA, especially in children.
Right, kids are more sensitive. And the contrast kidney issue, CIN, you mentioned that's covered elsewhere.
Yeah, contrast-induced nephropathy is a whole topic in itself. Risk factors, prevention, debates about how common it truly is. Rutherford's has a dedicated chapter on arteriography and contrast agents that goes into detail.
Okay, risks acknowledged. What about things that can just mess up the images? Artifacts.
Oh yeah, lots of potential pitfalls. Partial volume artifacts happen when a structure is only partly in the slice thickness. It can average the density and sometimes make it look like something's there when it isn't, like a fake lung nodule near the ribs.
Okay. What else?
Beam hardening is a big one, especially with metal. You get dark streaks or bands appearing near dense objects like prosthetic hips or metallic stents.
Can that hide problems?
Definitely. Those streaks can obscure anatomy right next to the metal, and the artifact itself can sometimes be misinterpreted or make a stenosis near a stent look worse than it is. Different metals cause different amounts of artifact. Tantalum and gold are often worse than steel or platinum. Interestingly, tantalum and gold cause minimal artifact on MRI.
You mentioned beam hardening from contrast too.
Yeah, if you inject in an arm vein, the really dense contrast coming up the subclavian vein can cause streaks across the upper chest, obscuring the aortic arch sometimes. Injecting in the other arm, or even a leg vein for IVC injection, can help if the arch is the main focus. And the arms down position causing streaks we talked about, arms up helps. Or using newer iterative reconstruction or specific metal artifact reduction, MAR software.
What about patient movement?
That's probably the most obvious artifact. Any movement, breathing, coughing, just fidgeting causes blurring or ghosting. Double contours? Pulsation from arteries can also cause artifacts. If someone can't hold their breath well, sometimes coaching them to breathe very shallowly and quietly is better than failed breath holds.
Any other common ones?
There's averaging artifact, where a tiny speck of bright calcium averages with surrounding low-density thrombus in an aneurysm, maybe mimicking a small contrast leak. Looking for inflow-outflow helps distinguish. Stair-step artifacts can happen on MPRs if the slices are reconstructed too far apart, making angled vessels look jagged.
Scanner problems.
Yeah.
Windowing errors.
Yep, equipment can malfunction, calibration can be off causing rings, and just setting the window width and level incorrectly can hide pathology. Too narrow a window hides density differences. Too wide washes out subtle contrast. Interpretation takes practice and awareness of these things.
You mentioned special care with children regarding radiation. Anything else for pediatrics?
The main thing is avoidance, if possible. Ultrasound and MRI don't use ionizing radiation, so they're strongly preferred in kids. If CT is absolutely unavoidable, it's ALRRA to the extreme. Accept potentially lower image quality if it's still diagnostic, just to minimize that dose. Every MSV counts more in a child.
Looking ahead, what's on the horizon for CT?
More 4D imaging, adding the time dimension to 3D, watching things move or perfuse. Techniques like diffusion and perfusion, already big in MRI, are getting better in CT. Continued improvements in detectors and those noise reduction algorithms always pushing for lower dose. And AI, or computer-aided diagnosis, CAD, will likely play a bigger role in helping analyze the huge data sets CT generates.
Okay, last big comparison. How does CT stack up against duplex ultrasound and MRA, summarizing the pros and cons?
Duplex ultrasound. Great for screening, non-invasive, no radiation, gives flow info, but very operator dependent, can be limited by patient size, gas, or heavy calcification, and often doesn't give the full anatomical map needed for complex endovascular planning.
MRA versus CTA.
Head to head. For aortic endograft planning, CTA often wins due to better calcium visualization. For heavily calcified tibial arteries, MRA might edge it out as calcium doesn't obscure the lumen. Overall, CTA is generally faster, more available, and maybe more reproducible scan to scan. But MRA avoids radiation and iodine contrast, though gadolinium has its own issues. They're often complementary.
You mentioned fusion imaging.
Yeah.
And peaky CT.
Fusion imaging is cool. It overlays the pre-op 3D CTA data onto the live X-ray image during surgery, uses bony landmarks to register them, helps guide wires and catheters in 3D, potentially reducing fluoro time, contrast dose, and procedure time. PTT combines the metabolic info from PT with the anatomy from CT. Big in cancer, but finding vascular roles too, looking for inflammation in infected grafts, vasculitis, or unstable atherosclerotic plaque. There's a whole chapter on that too.
This has been incredibly comprehensive. We've gone from the basic physics and history right through to cutting-edge applications and future directions. It's undeniable how much CT has revolutionized vascular care.
Absolutely. From those first slow brain scans to real-time 4D imaging, the evolution has been staggering. And understanding the why and how behind it, even at a high level, is really empowering.
It really is. Whether you work in healthcare or just trying to understand medical technology's impact, grasping CT fundamentals is, I think, pretty valuable.
Agreed. It demystifies a technology that touches many lives.
So, to leave you with something to think about, given how fast CT technology and especially the post-processing software are advancing, what completely new or perhaps unexpected ways might we see CT being used in vascular medicine down the road? And as we get ever more detailed, intricate data from these scans, what new ethical questions might pop up about how we use that information, or perhaps even about incidental findings?
That's a great point to ponder, the possibilities and the responsibilities that come with them.
Definitely something to consider. We hope this deep dive has given you a solid foundation. Thanks for joining us.